Thanks everybody for coming. We do, 2 to 3 of these per year, depending on, what we got. But this was an interesting case anyway that had a lot of information associated with it. So I thought that it was worth going over for sake of the group. So we're going to be talking about a participant and patient. He was 69 years old. He was medically, neurologically, psychiatrically healthy until he was 69 years old when he started having problems with cognition. And more specifically, described a lot of visual spatial problems where he missed a turn into the driveway of a home that he had lived in for over 20 years, having problems dressing himself, would put on shirts like backwards, having trouble getting pants on properly. It sounds like he would easily lose track of his tasks if interrupted and really wouldn't be able to return to sort of the stream of consciousness after being interrupted. Lots of trouble performing like multi-step tasks, like being able to work a computer, work a remote control anyway. On the memory side of things, he was beginning to misplace objects and more than just the usual, like, oh, I can't find my cell phone or keys. Occasionally, this was like a daily problem. And he was an avid cook in the family, but he was starting to leave faucets and burners on occasionally and needed to be corrected with that. He also played a lot of tennis and was having difficulty keeping score, especially on longer games anyway. So adding and subtracting during board games with families was becoming difficult as well. On the behavioral side, this didn't seem to bother him terribly much anyway. Overall, he did not seem terribly concerned about these deficits, but overall was becoming a little bit more withdrawn anyway, not engaging as much with social activities as was his norm before. A number of things that he denied on his initial evaluation. There wasn't really repeated questioning or repeated conversations at that point. There were no major changes in his fluency. There were not compulsive behaviors, was not overly rigid. There was no socially inappropriate behaviors with people. There were no descriptions of visual hallucinations or dream enactment, and no reported movement problems at that time of stiffness or slowness or tremor. His only past medical history was kidney stones. Those were not active at the time anyway. Initially, there was no reported history of dementia, Parkinsonism. His mother died at age of 26 of a ruptured brain aneurysm, and we're going to come back to that a little bit later. He was born and raised in Ohio. He had 3 half siblings, 16 years of education, had obtained a bachelor's degree and sold technical staffing services for a long time at the same company. He served 6 years in the Army Reserves, but it was always in a non-combat role, so didn't have any major TBI exposures or chemical exposures as part of that service. Taking no medications at this point. So unfortunately, he started getting sick when the pandemic was really in its initial stages. So he was initially seen by an outside neurologist over telemedicine. And this is sort of the early days of telemedicine too. So the notes are fairly scant and there's really no physical exam that's recorded, just a pretty detailed history at this point. And the outside neurologist at that point felt this was overall fairly concerning. And the workup they ordered included an MRI of the brain, an FDG PET study, and a full neuropsychological assessment that was offered on the clinical side. This looks a little different than what, oh, okay, here we go. So the neuropsychological evaluation was also conducted via telemedicine by Dr. Kalp anyway, who's associated with the Neuron Center. I try to highlight the significantly abnormal scores that were on this, but really there was a lot of problems with the Benson figure delayed recall at that point, really performing fairly poorly in the 3rd percentile, and also figure copy. And there's a little bit of a narrative that might be a little bit small for you guys to see in the audience. But so they did okay with clock drawing anyway, but had problems with the cube copy, problems with intersecting pentagons at that point. A lot of other scores were normal or near normal anyway. So the interpretation that Dr. Kalp had submitted to go along with the set of scores was saying this is somewhat limited by the fact that we had to do this over telemedicine, but there's prominent visual spatial deficits to the degree that they called this a mild cognitive impairment, and they offered a potential etiological differential diagnosis that included posterior cortical atrophy, potentially due to Alzheimer's disease, or maybe dementia with Lewy bodies at that point. We are going to see if this works. This was the MRI brain. It was a year He was about a year into his disease course at that point. Okay, so I knew that was going to be fast, but I wasn't hoping to do this and then let it spin through one more time so I can do this. So what I tried to pull up for you guys was a T2 flare axial cuts of the MRI brain anyway. I was hoping to kind of use this as a slider so we could go back and forth. But the cuts are still pretty thick as it was curated into a video. But you can see already that there's pretty prominent medial temporal lobe atrophy, especially on the right side. There's a little bit of ex vacuo dilatation, especially the right lateral, posterior lateral ventricle. You're getting up into the higher side. You're also seeing this right lateral ventricle is a little bit bigger than the left side. It's probably because he's got some atrophy on the side of the brain. It's a little bit worse. You get up a little bit higher. You see that there's atrophy that's affecting both parietal lobes all the way up into the top. Well, that didn't work great, but that's one of the reasons why we took these other screenshots of probably the most pertinent areas anyway. But again, these are now T1 axial images of probably the most important cuts anyway. But what you're seeing is a lot of atrophy, especially this right side. Midbrain looks okay. You go up a little bit further, you see a bit of orbital frontal atrophy too, but again, the right side is fairly hit. Same thing up here, but there's really a lot of posterior atrophy. Both sides, right's a little bit worse than left, but definitely pretty abnormal looking brain MRI from a structural standpoint for somebody who's 70 years old. And this is an FDG PET study that had been obtained for him on the clinical side around the same time. And as you can kind of see from, I don't know how many of these things you guys look at anyway, but, you know, warmer colors, reds and yellows indicate higher degrees of glucose metabolism in the brain. And then cooler colors mean that there's less glucose metabolism, hypoactive areas of the brain. And in this case, you can kind of see also that the right side is very much less active than the left side. It's very asymmetric anyway. Really, most of the frontal lobe, especially that right parietal lobe anyway, especially on that top cut, is really not metabolizing any glucose anyway, indicating it's a very hypoactive area of the brain anyway. This was interpreted as being potentially consistent with a frontotemporal dementia. Because again, there was a lot of fronto and temporal and parietal too, anyway, hypometabolism. So that was the radiologist's interpretation of this scan. For what it's worth, the basal ganglia look pretty good. Anyway, this is not really how these things are designed, but you can see FDG PET decrements in things like Parkinson's disease and PSP and other Parkinsonian syndromes. Okay? But those actually look pretty good. So he originally got referred to the UCSD clinical side to the movement disorders clinic anyway, and saw Dr. Litvan. And she and the fellow who saw him largely corroborated the history, but added that there were 4 cousins on the maternal side who had a diagnosis of frontotemporal dementia. And they were actually participating in a clinical research study in Italy. And at that point, not much else was known about that. She and the fellow documented a pretty abnormal neurological exam, which was significant for left-sided visual neglect with a mild left-sided akinetic rigid Parkinsonism, so sort of in the 1 to 2 out of 4 bradykinesia and rigidity scores. And they said that this person had normal eye movements at that point. So there's Parkinsonism, but also a lot of visual neglect. And at the end of this, she offered a clinical diagnosis of probably frontotemporal dementia with some cortical basal syndrome like features, and etiologically entertained cortical basal degeneration, or atypical AD, or potentially a TDP-43 pathology as being causative of the clinical syndrome. And at this point, 2 things happened. They was referred to the all-FTD study, which is a longitudinal natural history and biomarker study of all frontotemporal dementias, been running for a handful of years and recently got another renewal, thank goodness, anyway. But it does include cortical basal syndrome as part of the things that they follow. And on the clinical side, they were pursuing genetic testing because now they've discovered that there's a fairly prominent history of probably FTD on the maternal side. Anyway. This is a copy of the person's MoCA. Also at that time, and what you're seeing is a lot of trouble with visuospatial. I actually would have scored this lower. You can see that the numbers in the clock are not really aligned. should be, and certainly the copy rectangle and the trails are definitely not getting any points there. Problems with attention, also, especially the calculations and subtraction area too. But a lot of other stuff is pretty good. Gets points for decent amount for delayed recall. Orientation's totally fine. The language testing, he did pretty well, except for one thing. So, but pretty still isolated domain deficits that are mostly visual, spatial, executive, and now some calculation stuff too, anyway. Also got referred to UC San Diego's Cognitive and Behavioral Neurology Department and was seen by Dr. Legere. At that point, this person was 72 and now about 2-ish years into the disease course. At that point, Dr. Legere said that unfortunately he was becoming more withdrawn, becoming more disoriented in the house, saying, oh, can you go up to the bedroom to go get your shirt or something? You go downstairs instead of upstairs. So a lot of visual spatial issues there, and now starting to spill food on the left side of his plate, preferentially anyway, which is something we don't hear about all the time, but apparently was happening with him. And on the exam portion of this, Dr. Legere documented really striking apraxia and left-sided visual spatial and tactile neglect. Now, I'm presenting this in sort of the order that it happened for the clinical workup and everything. The genetic testing had come back at that point and was significantly abnormal for a pathogenic mutation in the progranulin gene. Anyway, we'll talk a little more about progranulin mutations a little bit later. So on the basis of his progranulin mutation and cortical basal syndrome phenotype, he actually got involved in a pharmaceutical trial with Elector. This was for this compound latinezumab, anyway, which is a monoclonal antibody, and it's supposed to work by helping to increase progranulin activity. So with progranulin mutations, they're loss of function mutations. If you lose 2 of them, you get this childhood disease, neuronal ceroid lipofuscinosis. But if you have 1 mutation, anyway, that's a loss of function, you have this usually autosomal dominant family history of some version of FTD. And there's a lot of pleiotropy of what type you might present with anyway. But the idea with latinezumab, anyway, is that progranulin is normally degraded by an enzyme called sortilin. And this now antibody that they were trying to test anyway was supposed to bind up the sortilin, so your naturally occurring progranulin from your good allele anyway would be allowed to stay around a little bit longer and maybe rescue a little bit of function anyway. So latinezumab has been studied in a couple of different settings anyway, and he was involved in one of these studies that we were conducting here at UCSD. It's an IV thing. You got to do it every 4 weeks, basically. So the clinical course, regretfully, though, despite being involved in the clinical trial, was pretty precipitous, though. He started having a lot of problems with falls, lots of visits to the emergency room, lacerations, and having to get him up off the floor when family couldn't right him on their own. This is about 2.5 years into his disease course. The apraxia and hemi-neglect really seems to be quite marked at this. And at this point, the left leg is becoming stiffer and uncoordinated, and people are starting to notice sort of myoclonic jerks, mostly of the left side. 3 years into his disease course or so, he becomes bedbound, really because of these frequent falls anyway. Really needs help with all activities of daily living and needs to be fed at that point, and has been noticed to have some deficits with chewing and swallowing, coughing on liquids when trying to drink water. Ultimately was referred to hospice care and stayed on hospice care for about 1.5 years before he ultimately passed away. And this was about a 5-year disease duration from the time that he first presented to care until, unfortunately, he passed away and donated his brain. But the assessments here on the right are from his last clinical visit with the cognitive behavioral neurology group here, scoring a 14 out of 30 on the mini mental status exam. And you can really see how poorly he's doing with visual spatial function anyway, can no longer write a sentence at this point either, and really stark examples of this sort of hemi-neglect, visual spatial issues at this point, where he's only drawing stuff on the right side of the clock, and this is not even close to correct. And on one of these cancellation tests, usually what we'll do if we're going to do something like this is put a bunch of stimuli on this and say, hey, cross out all of the letter A's. And he's only hitting some of the letter A's that are on the right side, indicating that he's not able to pay attention to this left side of the world anyway. So I want to talk about cortical basal syndrome as a clinical entity a little bit, because when I'm teaching our clinical fellows anyway, I do spend a little bit of extra time on this one because it's pretty much the thing that we're the worst at in terms of taking a clinical syndrome and trying to tag it to an etiological pathology anyway. So these are some of this is actually from the last consensus clinical criteria diagnosis. It was from 2013. So it probably is due for an update pretty soon anyway. But these are the syndromes that are supposed to be emblematic of cortical basal syndrome and likely to be from cortical basal degeneration as a pathology. Now, this gets a little bit messy, and you guys will sympathize with this, but sometimes when I'm talking to other people, they don't really get this. But I'm going to try to use as much as I can cortical basal syndrome to describe a clinical syndrome and cortical basal degeneration only for a neuropathological finding because the association is so poor. So of things that are associated with the neuropathology, they talk about probable and possible cortical basal syndrome anyway. But the clinical findings tend to be very asymmetric limb rigidity, usually a fair amount of dystonia with the hand too anyway, very curled up anyway. There's often limb myoclonus and apraxia. You'll get cortical sensory deficits as well. Problems with calculations, problems with double simultaneous extinction, and sometimes a little bit of alien limb phenomenon where the limb will float or start to do kind of odd things that the person isn't fully in control of anyway. But besides cortical basal syndrome, there's other clinical findings that are often associated with the pathology, and that includes an FTD syndrome anyway. So it's funny, if you talk to movement disorders people, we think cortical basal syndrome is an atypical Parkinsonian syndrome. If you talk to cognitive behavioral guys, it's a variant of frontotemporal dementia. So this is where our overlap is anyway. But if they're going to have an FTD-like syndrome, it tends to have executive function, behavioral personality changes, which this guy only had a little bit of, but also prominent visual spatial defects, which this person had very badly anyway. There can be a language variant, and if it is going to be a language variant, it tends to be a non-fluent agrammatic aphasia with short sentences, lack of grammar anyway, one or two word answers at the end. And sometimes they can even have a PSP-looking syndrome too. But this is kind of to highlight some of the points I was trying to make before. All of these left pie charts are from several different brain banks around the country, actually around the world. A couple of them are outside the US, where they looked back at everybody who had been diagnosed with cortical basal syndrome and then look back at what neuropathology these people actually had at autopsy. And even if you don't have to squint to see the numbers, but you can see the pie charts are like very evenly distributed. So only like a third of people who are diagnosed with CBS, cortical basal syndrome, will actually have CBD pathology underneath. And other things that can give you a syndrome, atypical Alzheimer's disease, progressive supranuclear palsy pathology, FTLD TDP43 is on there. And often even with the AD people, they can have a little bit of Lewy body pathology too. And actually all of the stuff on the right side is from a case report that we had published a couple of years ago for somebody who also had a lot of clinical and biomarker signatures from a different natural history study that I was involved with a few years ago. And this person had a tau PET scan showing very heavily right lateralized tau deposition anyway. And when they came to autopsy, their tau pathology, which is a little bit different than what we usually do, we actually ended up getting histochemistry on both sides of the brain, which is not something that we routinely do. But for this person, we did, and we saw very heavily right lateralized tau pathology, but also very heavily right lateralized alpha-synuclein pathology too. That was pretty bad also. So I'm trying to make the point here that there's lots of different pathologies that can lead to the same type of clinical presentation anyway. So you have to think carefully. It's a syndrome that is really useful for biomarker characterization if you want to try to tease out what's causing the symptoms in front of you. Now, you guys already have the answer, but if I was trying to do this with our fellows anyway, I'd ask them to take a step back and say, okay, well, you had a really strong family history. Let's kind of like try to form a differential diagnosis of what you think is going on. And I made a little pedigree. So this is our proband. Mom passed away, and we don't really know, it wasn't in the notes like what the sexes of any of these people were anyway, but apparently all of these cousins are affected anyway, the ones that are involved in the Italian study. So if you take a look at this for a second, this is not consistent with an autosomal recessive type of condition. You can't really make it work that way. Arguably, depending on if you knew the sexes, there could potentially be an X-linked disorder, but we don't really see a lot of X-linked dementia syndromes anyway, not with a cortical basal syndrome presentation. So to be honest, this is probably an autosomal dominant, the inherited condition if you just look at the pedigree. But that does mean that his mom would have been an obligate carrier anyway. Now, she passed at 26, never would have had the chance to become symptomatic in a sense. It also means that this person is probably an obligate carrier too. And that we just didn't have much information on those other people right now. Okay, so what causes autosomal dominant style FTD syndromes? MAPT mutations, which causes tau pathologies, sometimes pretty interesting tau pathologies, has been documented and published to cause cortical basal syndrome. Presenilin type 1 mutations technically have been reported, although not very commonly, to give you cortical basal syndrome phenotypic presentations. And then there's progranulin, which causes TDP43. And again, so those would be the three. If we just like talk to this person before you did any testing, these would be top three on my list. It's going to be one of these things. Now you guys already know the answer because we did the testing and we got the progranulin mutation.
So this is just to reiterate what Dave just told you about how cortical basal syndrome can result from a lot of different neuropathologies. And that's kind of the view I took going into this brain autopsy. And for full disclosure, I was not aware of the granulin mutation at the time I looked at the brain. So I kind of worked my way backwards. But so going in with that history of cortical basal syndrome, we're looking for different types of frontotemporal dementias. Could this just be a very unusual Alzheimer's disease presentation? And even you can see some of these cases were caused by Lewy body disease. So pretty broad neuropathologic spectrum that could result in the same clinical syndrome. So before we actually look at the patient's pathology, for any trainees in the room, I kind of wanted to go over the typical pathologies that we look for in these Alzheimer's disease, the ADRC research brains that we receive. So of course, we're always looking for Alzheimer's pathology. And the two things we're looking for in Alzheimer's are neurofibrillary tangles, which are abnormal accumulations of tau, as well as amyloid plaques. And so this is showing you in Alzheimer's disease brain, there's neuron loss evidenced by these reactive astrocytes here in this circle. And this is a nice neurofibrillary tangle, this kind of flame-shaped and yarn-like structure in this neuron here. And if you did a tau immunostain, which we routinely do, you would see that would highlight these flame-shaped neurofibrillary tangles. And then the counterpart that goes along with tau and Alzheimer's disease is amyloid plaque. So this is a beta amyloid stain, and you can see this cortex is just full of a bunch of amyloid plaques. Some of them have these dense amyloid cores. And another pathology that we frequently pick up in Alzheimer's disease patient brains is amyloid angiopathy. So you can see some of these vessels in the leptomeninges and superficial cortex are also highlighting with the amyloid stain. So that's just the pathology of cerebral amyloid angiopathy that frequently occurs in the setting of AD. And then we also look for Lewy bodies. So when I say Lewy bodies, I mean abnormal accumulations of the protein alpha-synuclein. And of course, the most classic association with that would be Parkinson's disease. So this is just to show you a Parkinson's disease patient, substantia nigra, with complete pallor compared to the nicely pigmented substantia nigra in a healthy patient. And that corresponds microscopically to loss of these pigmented neuromelanin-bearing neurons in the substantia nigra. So this center picture here compared to a normal patient on the left. And the pathologic substrate here is Lewy bodies, which again are alpha-synuclein. So these are these cytoplasmic eosinophilic inclusions with this peripheral halo around them. And we do have stains for alpha-synuclein that we can use to pick up Lewy bodies. So if this is in the brainstem, in the substantia nigra, we think Parkinson's, but you can also get Lewy body dementia where it's more of a cortical disease, and we look for both. And then in this case, a big differential that we're thinking about is frontotemporal lobar degeneration, or FTLD. And FTLD has gotten pretty complicated as they've sorted out the different proteins that can result in the clinical kind of syndrome of FTD. And we break it down by those proteins. And the two big categories are either tau positive or ubiquitin positive tau negative. And tau positive is even further broken down depending on the isoform of tau. So your tau protein can be broken down either as 3-repeat or 4-repeat. So some diseases have both isoforms of tau. For example, Alzheimer's disease, you get both 3R and 4R tau, but some diseases are characterized by just one of those specific isoforms. So for example, Pick's disease, which is kind of like the classic frontotemporal dementia, is a 3-repeat or 3R tau. And corticobasal degeneration, which we're of course interested in this case of corticobasal syndrome, is a 4-repeat tau, as is progressive supranuclear palsy, agyrophilic grain disease, and globular glial tauopathy. So a lot to kind of digest here if we happen to see tau in this patient's brain. On the tau negative but ubiquitin positive side, the biggest category here that we're going to focus on is FTLD TDP43, so TAR DNA binding protein 43. That will encompass most of these tau negative cases of FTD. There are some other rare proteins like FUS that can also lead to a frontotemporal dementia that we won't focus on too much today. So just to briefly review what we would see in these different FTLD syndromes. So for Pick bodies or Pick disease, you would see 3R tau. And again, we can specifically stain for that isoform. And so you can see these nice cytoplasmic rounded Pick bodies. Versus the 4R tauopathies, which the big two are corticobasal degeneration, or CBD, and progressive supranuclear palsy, or PSP. So the big difference between CBD and PSP, though they're both 4R tauopathies and part of the frontotemporal lobar degeneration spectrum, is that in CBD you get a lot more cortical involvement. So you can see in this gross image on the left, the cortex is much more atrophic in the CBD case than in the PSP case. The CBD case often will also show thinning of the corpus callosum. There's a little bit of hydrocephalus ex vacuo here. And the PSP case is probably a little hard to see here, but oftentimes the subthalamic nucleus is quite atrophic. And these can be a little tricky histologically to sort out because they're both going to be 4R tau positive pathologies. And they like to say that CBD has these astrocytic plaques, which is in panel C here, versus PSP has tufted astrocytes. And they picked some very nice examples here that look quite a bit different. But in real life, they can overlap quite a bit. So you kind of have to put the pieces together of where you're seeing the pathology, the gross, and all the features to kind of decide on these entities. But they're kind of, we think of them almost as a spectrum. And then lastly, TDP43 pathology. So TDP43, we can look at in two ways. We can look at the total protein TDP43, which is what's shown here, or the phosphorylated protein, which is abnormal. So total protein, we all have it. It's normally there in the nucleus. So this nuclear staining is actually normal. And if you use the total TDP43 stain, what you're looking for is nuclear to cytoplasmic translocation. So you can see this is a nice cytoplasmic inclusion, and the nucleus is now blue because it's lost the TDP43. Versus if you're using the phospho TDP43 stain, any staining is abnormal because it's hyperphosphorylated. And this is further broken down, the FTLD TDP43, into these different types, A through E, based on the pattern of pathology you see. So these Roman numerals here on the left are just referring to layers of your neocortex. So you can see different patterns are kind of limited to different layers. So type A and type C tend to be in the upper layers of the cortex, versus types B, D, and E are more diffusely throughout the cortex. Some of these will also have white matter involvement. And then the morphology of the inclusions is going to change. So these little ones that look like cat's eyes, those are lentiform intranuclear inclusions, which are really prominent in this subtype D, but you can see in A. And the little strands are dystrophic neurites. So we're going to, if we see TDP43, we're going to have to look very carefully and see what kind of inclusions or abnormal staining we see and see if we can fit it into one of these types. So now let's move on to the actual patient's pathology. So just keep in mind, we have the left hemibrain here. So the right hemibrain, which seemed like it was much more affected clinically and based on his imaging, was frozen for future research, but the left was placed in formalin for me to examine and give a diagnosis. So things might have been much more severe had we received the right half of the brain. So you can see here, I peeled off the leptomeninges in the frontal and parietal cortex, and there is quite a bit of atrophy. So there's thinning of the gyri and widening of the sulci here. It doesn't necessarily, sometimes in like Pick's disease or certain forms of FTD, you'll see a pretty stark cutoff of frontal and temporal with the parietal and occipital spared, but that wasn't so much in this case. This was more almost a global atrophy. And you can see the brain weight, the hemibrain weighed 588 grams, so the calculated weight is 1176 grams, which is a little light. So for a normal adult male, would depend on height, but usually we think like 1,300 to 1,500 grams. So there's definitely evidence of atrophy just based on the weight. And here are a few representative coronal cross sections. So at the ADRC, we're always interested in the hippocampus. You can see in the right image here, this is the posterior hippocampus, this seahorse-shaped structure, and it looks pretty good. It doesn't look particularly shrunken. There's not much ventricle enlargement of the temporal horn around it. So if this was really severe AD, you would expect much more hippocampal atrophy.
This is the left side.
Correct. And you can also see there's a little bit of hydrocephalus ex vacuo. So these ventricles are a little enlarged and blunted, which is resultant from the surrounding cortical atrophy. The basal ganglia look pretty okay. So this is the caudate and putamen, just as Dave showed on the imaging. They didn't look particularly affected, at least grossly. And this is just to show you that his substantia nigra was very well pigmented. So then we'll move on to the patient histology. So this is a low power view of the middle frontal gyrus. So we have the peel surface up at the top and then the layers of the cortex going down here. You'll see a lot of vacuolization. That's likely just artifact from delayed processing. So don't worry too much about those little white spaces. But overall, there was maybe a mild suggestion of neuronal loss, but not much gliosis that I could see in most of the deeper layers of the cortex. But you can kind of appreciate this more superficial cortex looked a little pinker even at low power. There's almost this band. And there was some increased astrocytosis here. So a little bit of gliosis in the superficial layers of the cortex, but still pretty good neuron populations. You can see all these big pyramidal neurons down here. So then we move on to the anterior hippocampus, which we recognize by this kind of double hump formation. It looks pretty robust, didn't look grossly or at low power like there was significant atrophy. And when we take the section of the anterior hippocampus, we specifically take it to also sample the entorhinal cortex. And the reason we do that is the entorhinal cortex and the transentorhinal cortex are really where Alzheimer's disease starts. So the lowest stage for tau pathology is when you just have tau in the entorhinal cortex. And so there's neuron clusters in layer 2 of the entorhinal cortex, one which is shown in this image. So that's a great place to look for tau tangles and neuron loss in Alzheimer's disease. I really didn't appreciate much. These looked like very well-populated neuron clusters, and I wasn't able to identify any tangles on H&E. So far not looking like Alzheimer's disease. And then we, of course, look at the posterior hippocampus. You can see the dentate granular neurons here, which kind of point toward the CA1 or cornua manus 1 region of the hippocampus, which we're very interested in. At low power, it doesn't look particularly shrunken. But when we go to higher power and compare the different regions, look at CA2 on the right first, you can see a nice population of pyramidal neurons. CA1, they're almost all gone. So it was a pretty abrupt transition where in CA1, there was pretty much near pyramidal neuron loss and gliosis that could meet criteria for hippocampal sclerosis in the CA1 region. And then just to show you his basal ganglia, so this is a section of putamen, and these are the pencillary bundles of Wilson, these little white matter bundles that go through the neostriatum. And it, again, vacuoles are artifact, but it appeared pretty well populated, didn't appreciate much gliosis. And his substantia nigra, as we thought based on the gross, was, again, very well populated, well pigmented, and I did not appreciate any Lewy body pathology. So that was just based on the H&E, but we're still going to go through our standard stains. So we'll look for tau, we'll look for amyloid, we'll look for synuclein, and we'll look for TDP-43. And then we're going to stage this. So for amyloid, the first thing we look at is there amyloid plaques? And that is the thaw phase. So the first place that plaques will appear is up in the neocortex. So this is, again, the middle frontal gyrus. This is a beta amyloid stain. And you can see there is some diffuse plaque staining. But anyone at this age is probably going to have a little bit of plaques. So we don't know if we should make too much of this quite yet. And then we move on to the next area where it typically spreads, which would be around the hippocampus or entorhinal cortex. And this was completely negative. So if you look at our thaw phasing, because this is limited, the beta amyloid is limited only to the neocortex. We don't see it in the hippocampus. We also stained the basal ganglia, the midbrain, and the cerebellum, which were all completely negative. This is a very low thaw phase of 1, which again is pretty typical for a patient of this age. Then we do the Brock staging. So if you've ever heard of Brock staging, that's actually the tau or the tangle burden in Alzheimer's disease. And so we do a phospho-tau stain. And again, the first place that Alzheimer's disease tau pathology starts is the transentorhinal and entorhinal cortex. And so this is from that section. This is one of those neuron clusters in the entorhinal cortex. And there's like 3 tangles. But again, anyone at this age, you'd be kind of surprised if you didn't find any. And we didn't see any tau really anywhere else. So this is super low Brock staging, just limited kind of to the transentorhinal region. We didn't really appreciate any tangles in the hippocampus proper. So this is a stage 1 Brock. So very low Brock and thaw. And the last part of Alzheimer's disease staging is CRAD. So we have the A, the thaw, the B, the Brock, and the C for CRAD. So ABC staging. And CRAD is looking at plaques again, but specifically neuritic plaques. So those plaques I showed you on this patient's amyloid stain were diffuse plaques, but neuritic plaques have dystrophic neurites associated with them. So you can look for them on a tau stain or a silver stain. And we just grade this based on the density, how frequent we see these plaques. And I did not see any neuritic plaques in this patient. So he got a C0. So once we have all those scores, the A, the B, and the C, we can then use this chart to kind of assign whether it's low likelihood that there was Alzheimer's disease, intermediate, or high. So based on this, he had low Alzheimer's disease neuropathologic change. So that doesn't seem like it's going to explain all his clinical symptoms. So what about alpha-synuclein? Nothing there. I won't show you negative stains. That would be pretty boring, but we did not see any alpha-synuclein in the amygdala, the cingulate gyrus, or the superior temporal gyrus. In addition to, I didn't appreciate any Lewy bodies in the substantia nigra. So now we're getting to the good stuff. So what about TDP-43? So remember, this is the left side of his brain. His pathology might have been worse on the right. This is the middle frontal gyrus again. And we use a phospho TDP-43 stain, so any brown staining is abnormal. And at low power, it doesn't look that impressive. But you squint and you can start to see a few little brown dots. And when you go to higher power, there is some abnormal staining. So we have these kind of short little strands, which are those dystrophic neurites we saw in that table earlier. There's some cytoplasmic inclusions, some of them kind of C-shaped or ovoid. And then this is actually a really nice kind of lentiform or cat's eye intranuclear inclusion. And although it wasn't that impressive at low power, this was kind of scattered throughout the upper layers of the cortex, so layers 1 through 3. And we also did TDP-43 staining in the superior temporal gyrus, which showed a similar pattern, some of these short neurites, some cytoplasmic inclusions. And we went back to the hippocampus, where, again, we saw that really severe neuron dropout in CA1, meeting criteria for hippocampal sclerosis. And again, at low power, it doesn't look like much, but there were a few strands and cytoplasmic inclusions in that region where we saw that neuron dropout. So if we go back to our chart of frontotemporal lobar degeneration TDP-43 subtypes, and we try to match up our patient's pathology with one of these types A through E, ours was limited to the upper layers of the cortex. We saw some short kind of dystrophic neurites. We did see a rare lentiform intranuclear inclusion, and then some of these kind of C-shaped or ovoid cytoplasmic inclusions. It didn't really involve the whole cortex. It wasn't just these long dystrophic neurites, and that it didn't have this granular staining of type E. So this fits best with a type A pathology of FTLD TDP43. And so that actually fits quite nicely because I had cut this part of the chart off earlier when I showed it, but you can see down at the bottom there, genetic associations with type A FTLD are associated with progranulin mutations, which were identified in this patient and fit with his strong family history. So the final diagnosis in this case was frontotemporal lobar degeneration with TDP43 pathology, specifically the type A subtype. And again, he had a low Alzheimer's disease neuropathologic change score. So what do we know about FTLD TDP43, specifically this type A subtype? Most often, clinically, these patients are going to present with a behavioral variant, frontotemporal dementia with prominent apathy and social withdrawal, which it sounds like this patient did have quite a bit of withdrawal. They can present with primary progressive aphasia, but this is less common than the behavioral variant. And they often have some degree of executive dysfunction and memory impairment. In the autosomal dominant cases, which can be associated with either progranulin, as in this case, or the C9orf72 mutations, they're more likely to get delusions, hallucinations, and obsessive behaviors, and about 50% will have extrapyramidal features. And just to review the pathology one more time, so the pathology can be kind of broken down into what you would see in the neocortex and then what you would see in the hippocampal region and subcortical structures. So in the neocortex, again, in type A, typically the pathology is limited to that superficial cortical layer. You have both neuronal cytoplasmic inclusions and then the less abundant intranuclear kind of lentiform inclusions. And then you have these short, thick dystrophic neurites. Some of the other types have these really long, slender neurites, but the short, fatter ones are more typical of this type A pathology. And what's interesting and how our case fits very well is in the hippocampus, you tend to get hippocampal sclerosis with TDP43 pathology and CA1, which is exactly what we saw in this patient's hippocampus. You often will see abundant white matter threads. That wasn't really prominent to me in this particular case, but I wonder maybe on the right side, they would be more abundant. And this is just a little overview of what the function of the progranulin gene is. I will not pretend to be an expert in its function, but basically the progranulin gene encodes for the progranulin protein, which can then be broken down into these granulins, hence the name progranulin. And what we know about progranulin and the granulins is that they're important in regulating cell growth, survival, repair, and inflammation. And they're thought to have a major role in the regulation of lysosomal function, as well as microglial responses. And as Dave mentioned earlier, what's interesting about this and why that fits that lysosomal function is if you have a single copy, you get this autosomal dominant FTLD, but if you have two copies of a mutant progranulin gene, then you get this lysosomal storage disorder with onset usually in childhood called neuronal ceroid lipofuscinosis. And that's all we had.